let us discuss about antihypertensive drugs. Before going into the pharmacology of antihypertensive drugs, let's give an introduction on hypertension. What is hypertension? Causes of hypertension, what are the risk factors involved in hypertension, and what are the diagnosis tests involved in the hypertension. What is hypertension exactly? Why the condition is called as hypertension? Normally, the blood pressure which is exerted by the heart is 120 by 80 mm of Hg. 120 refers to systolic blood pressure and 80 mm of Hg refers to diastolic blood pressure. So, this is the normal or ideal blood pressure in the human beings. But if this blood pressure is increased or it is greater than 140 mm of Hg of systolic pressure and 90 mm of Hg of diastolic pressure. That is 140 by 90. The blood pressure exceeds greater than 140 by 90. Then that condition is called as hypertension. Why this hypertension is caused? Or let us see what is systolic blood pressure exactly. 120 mm of Hg we are referring as systolic blood pressure. That is the pressure exerted by the ventricles when they get contracted. That is contraction of ventricles gives or it exerts blood with certain pressure. So the pressure with which the blood is exerted because of contraction of ventricles is called systolic blood pressure, and diastolic blood pressure refers to the relaxation or the pressure exerted by the heart when auricles, that is arteries and ventricles, both relax. Then that condition is called as diastolic blood pressure. If there is any disturbances in this normal blood pressure, then there occurs condition called hypertension or hypotension. Now, we saw that hypertension, if the systolic blood pressure is greater than 140 mm of Hg and diastolic blood pressure greater than 90 mm of Hg, then hypertension is caused. Arterial blood pressure is mediated by cardiac output and systemic vascular resistance. What do you mean by this? Arterial blood pressure, the pressure exerted by the arteries, it is mediated by cardiac output as well as systemic vascular resistance. Systemic vascular resistance is the resistance to the flow of blood in the systemic circulation except pulmonary circulation. Apart from pulmonary circulation, the other systemic circulation, if there is any resistance to the flow of blood in such systemic circulation, that is called as systemic vascular resistance. And this arterial blood pressure is calculated by multiplication of cardiac output and systemic vascular resistance. What is this cardiac output? Cardiac output is nothing but the stroke volume into heart rate. The stroke volume, the volume with which the volume exerted by the heart is called as stroke volume, and heart rate, the rate or the number of beats of heart. So when these two parameters are multiplied, then the result is cardiac output. That is the volume exerted by the heart when certain heart rate, normal heart rate is 72 beats per minute. So at 72 beats per minute, whatever the volume exerted by the heart is called as cardiac output. And systemic hypertension necessitates an increase in the cardiac output or systemic vascular resistance. Once there is hypertension in the systemic circulation, then there will be definitely increase in the cardiac output as well as systemic vascular resistance. Let us see the factors which are involved in cardiac output increase or which influences or there is some fluctuations in the cardiac output. Let us see what are those factors. There are two types of factors, that is factors affecting heart rate and the other one is factors affecting stroke volume, because cardiac output is the result of heart rate and stroke volume. So let us see the factors which are affecting heart rate. One is autonomic innervation, the other one is hormones, fitness levels and age. As the age increases, then definitely heart rate will decrease, and when we are not fit, then definitely heart rate or the heart will not beat in a proper manner. And hormones, if there is any disturbances in the normal hormone level, then there will be increase or decrease in the heart rate. And factors affecting stroke volume, heart size, because the size of the heart, it depends on how much the heart exerts the volume out of the, or how much blood is exerted out of the heart is calculated by the heart size. And fitness levels, again gender, depending upon whether the male or female, the stroke volume is differed. And contractility of the heart, the contractility, how the heart is contracting, based on that also stroke volume is calculated. Duration of contraction, preload and afterload resistance. So when preload and afterload varies, then also stroke volume will vary. And As we saw, cardiac output is the result of heart rate and stroke volume. Modulators of cardiac output. Cardiac output can be modulated by total body sodium content. Based on the sodium present in the body, cardiac output can be calculated, and the contractility or heart rate. Based on the contractility of the heart or heart rate, cardiac output can be modulated or calculated. And what are the modulators of stroke volume resistance or systemic volume resistance? So modulators of systemic volume resistance are two factors. Humoral factors are there and local factors are there. Humoral factors are nothing but vasoconstrictors and vasodilators. So vasoconstrictors and vasodilators, they influence the contractility of the heart. So when vasoconstrictors like angiotensin 2, norepinephrine, thromboxane and endothelin, these are few of the vasoconstrictors which modulate or which influence the systemic vascular resistance. Vasodilators like prostaglandins, bradykinin and AMP. This is a type of vasodilator which modulates systemic vascular resistance. And local factors. Let us see what are the local factors. In the local factors also there are few vasoconstrictors and few vasodilators. Few of the vasoconstrictors like myogenic response, prostaglandins, leukotrienes and Aubin-like factor. See, the prostaglandins, there are few prostaglandins which act as vasoconstrictor and there are few prostaglandins which act as vasodilators. So it depends upon which prostaglandin increase or decrease is present in the systemic circulation. And vasodilators like endothelial ion channels. So when endothelium is when endothelium is dilated or where there is vasodilation occurs in the endothelium of the blood vessel, then also this systemic vascular resistance is modulated. Let us see the mechanisms. How BP can be regulated. This blood pressure regulation is acted by various mechanisms. Few of the mechanisms are sympathetic nervous system, like the drugs which are acting on sympathetic nervous system, and the other one is vascular endothelium. So vascular endothelium, the contraction or dilation of this vascular endothelium determine the regulation of the BP. And renal system, because if there is any disturbances in the renal system, then there definitely be increase or decrease, or there may be fluctuations in the blood pressure. And endocrine system, that is hormonal levels. If there is any fluctuations in the hormonal levels also, there may be fluctuations in the BP. So these are few of the mechanisms by which blood pressure can be regulated. Diagnosis test. How this hypertension can be diagnosed, or if the person is suffering from hypertension, how it can be diagnosed. Here also we have routine tests as well as optional tests. Routine tests include electrocardiogram, ECG, whatever cardiovascular disease it may be, based on the changes in the cardiovascular, that is PQRST waves, then definitely we can find out which cardiovascular disease the person is suffering from. So ECG test is the main test, or we can say it is the routine test by which we can determine the person suffering from which cardiovascular disease. The other one is urine analysis for proteinuria. So proteinuria, if there is increase or decrease in the proteinuria or urea in the urine, then based on that also hypertension can be diagnosed. And the other one is blood glucose. Based on the blood glucose level, serum, sodium and potassium, creatinine or calcium. If sodium, potassium, creatinine, calcium and glomerular filtration rate. So serum, sodium levels, potassium levels, calcium levels, creatinine or glomerular filtration rate. By diagnosing all this, by performing all these tests, we can find out whether the person is suffering with hypertension or not. And based on the lipid profile and eye examination, how we can examine with eye, because the person is suffering from hypertension, he will be more hyperactive and the anger will be more in that kind of person. And optional tests, if the hypertension is in severe condition, what are the tests to be carried out? X-ray test and 24-hour urine albumin excretion. So for every 24 hours urine should be collected and it should be done for the test of albumin. And now let us see the types of hypertension. There are two types of hypertension. One is primary hypertension and the other one is secondary hypertension. Or primary hypertension is called as essential hypertension and secondary hypertension is called secondary hypertension only. So essential or primary hypertension is caused due to the increase in the blood pressure, or if there is any fluctuations in the blood pressure directly acting in the body. And secondary blood pressure is caused as due to the occurrence of some other diseases, like if a person is suffering from atherosclerosis, then indirectly blood pressure increases, or if a person is suffering from angina or diabetes mellitus, indirectly blood pressure increases. So secondary hypertension is the addition or if the blood pressure which is caused because of other diseases. So that is called as secondary hypertension. And there are few environmental factors which causes hypertension, like stress. If a person have more stress, then there will be increase in the blood pressure. And sodium intake. If a person is taking more level of sodium inside or into the body, then definitely there occurs hypertension. And the other one is obesity. We have to be very careful in the obesity, or if we have to be very careful for our weight. If a person is overweight or if he is obese, then definitely the person is prone to more cardiovascular disorders. And smoking. Lifestyle has to be changed. Next, primary hypertension risk factors, because the main essential hypertension should be treated. Secondary hypertension can be treated by medication with other diseases, that won't be a problem. But primary hypertension risk factors, let us see. Age, as the age increases, then definitely heart rate will decrease. If heart rate is decreased, hypertension is caused. Alcohol, smoking, diabetes mellitus, elevated serum levels, excess sodium in the diet, gender, family history, obesity, sedentary lifestyle, stress. These are all the factors which cause hypertension or which causes more risk of primary hypertension. Let us see the identifiable causes of hypertension. What are the other causes through which hypertension can be caused? One is chronic kidney diseases. If a person is suffering from kidney diseases for a long time, for a chronic period of time, then definitely the person is prone to hypertension. Coarctation of aorta, that is, if the aorta, the artery which supplies blood to the heart, it gets contracted or it is obstructed, then definitely there occurs hypertension. And Cushing's syndrome. Cushing's syndrome is the case in which the hormone are increased. When the hormonal levels are increased, then definitely Cushing's syndrome will occur. Because of the Cushing's syndrome also hypertension can be caused. And drug induced. There are side effects of few drugs like hypertension. Hypertension may be the side effects of few drugs. Because of the drug induction also hypertension can be caused. And the other one is obstructive uropathy, pheochromocytoma, hyperaldosteronism. Pheochromocytoma and hyperaldosteronism, these are related to adrenal gland. Pheochromocytoma is like if there is any inflammation in the adrenal gland, then that condition is called as pheochromocytoma. And hyperaldosteronism, if the aldosterone levels are increased or aldosterone secretion is increased, then that condition is called as hypoaldosteronism. And renovascular hypertension, that is renovascular stenosis, and sleep apnea, and thyroid or parathyroid diseases. These are all the causes which leads to hypertension. Next. Now let us see the treatment of hypertension. How hypertension can be treated. So, the hypertension can be treated in both ways. One is non-pharmacological approaches and the other one is pharmacological approach or drug treatment. Let us see what are the non-pharmacological approaches. Like first, the person should lose their weight, and the alcohol or smoking should be limited, and increase aerobic physical activity. If we do physical activity on regular basis, we be fit, and thereby there won't be any chance of cardiovascular diseases, or cardiovascular diseases risk can be reduced. And reduce sodium intake. The sodium intake in our diet should be reduced, and maintain adequate intake of potassium, because sodium will cause contractility of the blood vessels and potassium will cause dilation of the blood vessels. So sodium intake should be reduced, and potassium intake should not be over, but it should be in a proper manner, or we have to maintain the sodium intake and potassium intake. Drug treatment. Let us see the pharmacological approaches or drug treatment. What are the drugs used in the treatment of hypertension? The first class of drugs include diuretics. Second class of drugs include beta blockers. Third class of drugs include alpha adrenergic blockers. Fourth class of drugs are calcium channel blockers. Fifth class of drugs are ACE inhibitors, that is angiotensin converting enzyme inhibitors. Sixth class of drugs are angiotensin 2 receptor blockers. Seventh class of drugs are beta and alpha blockers. Eighth class of drugs are central sympatholytics. And ninth class of drugs are vasodilators. So now let's see each and every category. Before going to the exact classification and pharmacology of these drugs, let us see lifestyle intervention for blood pressure reduction. How the lifestyle can be there, or if a person is prone to hypertension, how his lifestyle should be there. First parameter should be taken care is weight reduction. That is, maintain ideal body mass index. The body mass index according to our height, the body weight should be maintained. So body mass index should be maintained. And the other one is DASH eating plan. That is DASH. DASH eating plan includes, it is a 6-meal plan or 4-meal plan which we have to take. And it includes eat diet rich in fruits, vegetables, low-fat dairy products, eat less saturated and total fat. So the fruit intake, vegetables intake, that is healthy diet should be intaken properly. And dietary sodium restriction. The sodium or the food products which are more in sodium levels should be reduced, or the intake of sodium should be reduced. And physical activity. Daily we have to do at least 30 to 45 minutes of physical activity to maintain ourselves fit. And alcohol moderation. Alcohol or smoking consumption should be reduced, or it should be modulated if a person is more addicted. So alcohol and smoking should not be never quit at a time. They have to be quit, or the person has to reduce his intake of alcohol and smoke in a regular manner, because if they stop suddenly, then there occurs withdrawal syndrome, which is very dangerous. Now, let us see the classification of antihypertensive drugs. First class of drugs include diuretics. Diuretics are the drugs which act in the renal system. The first category of drugs in diuretics are thiazide diuretics, which include hydrochlorothiazide and chlorothiazide, and high ceiling diuretics called furosemide, and potassium sparing diuretics like spironolactone and amiloride. These are the class of drugs which are included under diuretics. And let us see the mechanism how these drugs act. So these diuretics act on the kidney by exertion of sodium and water. If the sodium and water are retented in the kidney, then there will be increase in the blood pressure. If sodium excess, that is excess sodium and water are removed out of the body, then definitely there will be proper balance of the blood pressure, and decrease in the blood volume and decrease in the blood pressure. If water or sodium is retented in the body, the blood volume will increase. If the blood volume will increase, the blood will exert out of the blood vessel with high pressure. So that is the reason blood pressure occurs. If these excess amount of sodium and water are removed out of the body, definitely blood pressure will be decreased. So this is the diagrammatical or pictorial representation. Each class of diuretics act on each part of the nephron. So nephron is the main unit of the renal system or urinary system. So these class of diuretics act on each part of the nephron. Like few diuretics act on loop of Henle, and few diuretics act in the distal loop. So the class of drugs varies. The point of action of these drugs varies. Let us see the other class of drugs, angiotensin converting enzyme inhibitors. So the drugs include captopril, enalapril, ramipril, lisinopril, fosinopril. And what is this angiotensin converting enzyme? So angiotensin is a potent vasoconstrictor. So this angiotensin, when it is released into the bloodstream, then there will be increased contraction of the blood vessel, which increases blood pressure. So the inhibition of synthesis of angiotensin 2, that is, first when angiotensin 1 is converted to angiotensin 2. So when angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, this angiotensin 2 is released into the bloodstream, which causes contraction. So when these angiotensin converting enzyme is inhibited, these are the drugs which inhibit ACE. So when this enzyme is inhibited, there the conversion of angiotensin 1 to angiotensin 2 is inhibited. When angiotensin 2 is not released, then definitely there occurs decreased contractility or vasodilation, and there may be decreased blood pressure. Angiotensin blockers, receptor blockers, angiotensin receptor blockers. So angiotensin will bind to the angiotensin receptors and then show its action. So 81 blockers, there are two types of angiotensin receptors, 81 and 82. So 81 blockers are losartan, candistatin, valsartan and telmisartan. So they block the binding of angiotensin 2 to the angiotensin receptors. When angiotensin 2 won't bind, then that will be in the inactive state. So if the angiotensin 2 is inactive, then there won't be any fluctuations in the blood pressure. This is the pictorial representation. First, angiotensinogen, which is released from the liver. Liver releases angiotensinogen. Angiotensinogen is converted to angiotensin 1 by renin. And from angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. And this angiotensin 2 will bind to 81 receptors or 82 receptors. But main mechanism is they bind to 81 receptors. So this binding of angiotensin 2 to the receptors is blocked. If that is blocked, then definitely there will be no increase in the blood pressure. Let us see the other class of drugs. These are potassium channel activators. Potassium channel activators include diazoxide, minoxidil, nicorandil and pinacidil. These are the drugs which come under the category of sodium channel activators. Sodium, when sodium is entered into the blood vessel, then there occurs dilation or decreased contraction of the blood vessel. So when sodium efflux is done into the blood vessel, smooth muscle relaxation will take place. This sodium when effluxed into the blood vessel, then there occurs decrease in the sodium and calcium levels in the blood pressure, which causes sodium and calcium causes contraction of the blood vessel. When potassium is entered into the blood vessel, then that causes hyperpolarization of the blood vessel and which ultimately result in the smooth muscle relaxation. This is the mechanism. Potassium channel openers allow the potassium efflux and that causes membrane hyperpolarization, which in turn decreases calcium entry into the blood vessel and that causes smooth muscle relaxation. Vasodilators. Vasodilators are the drugs which causes dilation or relaxation of the blood vessel. So when blood vessel is contracted, it occurs increase in the blood pressure. But if blood vessel gets dilated, then there occurs decrease in the blood pressure. So these are the drugs like arteriolar vasodilator, that vasodilation which is caused in the arteries. That class of drugs include hydralazine and arterioventricular, that is the vasodilation which occurs in both arteries and ventricles, that is sodium nitroprusside. Sodium nitroprusside causes vasodilation in both arteries and ventricles, but hydralazine causes vasodilation only in the arteries. These act by the mechanism of nitric oxide. When nitric oxide is released into the bloodstream, that causes increase in the cyclic GMP levels, that is guanylyl monophosphate. When the cyclic guanylyl monophosphate is released into the bloodstream, it causes dephosphorylation of MLCK, that is myosin light chain kinase, which causes smooth muscle relaxation. Next, the other class of drugs are calcium channel blockers. Calcium channel blockers include three categories of drugs. One is phenylalkylamines, second one benzodiazepines, third one dihydropyridines. The drug which come under the category of phenylalkylamine is verapamil. The drug which comes under the category of benzodiazepines is diltiazem. And dihydropyridines include three generations of drugs. First generation of drugs include nifedipine. Second generation of drugs include estradipine, nicardipine and felodipine. Third generation of drugs include amlodipine. Let us see mechanism of action. So as we all discussed, sodium and calcium influx into the membrane or into the blood vessel causes increased contractility of that particular blood vessel. So when calcium entry is blocked, these drugs block the calcium entry into the blood vessel. When calcium entry is blocked, then there will be reduced intracellular calcium, whereby relaxation of the smooth muscle takes place. When smooth muscles are relaxed, then definitely there will be decrease in the blood pressure. Next, beta adrenergic blockers. There are two drugs. There are two types of beta adrenergic blockers. One is non-selective and the other one is cardio-selective. Beta adrenergic blockers or beta adrenergic receptors are of three types: beta 1, beta 2 and beta 3. So non-selective beta adrenergic blockers can bind to any of the three receptors, but in beta or cardio-selective, beta 1 selective or beta 2 selective or cardio-selective drugs will bind to only particular beta receptor and show its action. Non-selective beta adrenergic blockers include propranolol, nadolol, timolol, pindolol and labetalol. And cardio-selective drugs include metoprolol, atenolol, esmolol and betaxolol. All these bind to the beta 1 receptor because beta 1 receptor is present in the cardiac muscle. Next, specific alpha-1 receptors. Adrenergic receptors are of two types, alpha as well as beta. Alpha also we have three types, alpha-1, alpha-2 and alpha-3 receptors. So these selective alpha-1 receptors or these selective alpha-1 blockers will bind to the alpha-1 receptor and exert their action. The drugs include prazosin, terazosin and doxazosin. Central sympatholytics. Central sympatholytics are the drugs which act on the sympathetic nervous system and exert their action. They are methyl-dopa and clonidine. Thus, the pictorial representation when adrenaline or noradrenaline will bind to the alpha or beta receptors. When they bind to the alpha receptors, they show smooth muscle contraction. So, these alpha adrenergic blockers will block or they won't allow the adrenaline or noradrenaline to bind to the alpha or beta receptors, and they get bind to those receptors and thus the adrenaline or non-adrenaline pharmacological action is nullified. When these noradrenaline and adrenaline becomes deactivated, that cause smooth muscle relaxation. Let us see RAS system. What is this RAS? Renin-angiotensin system. So renin is a proteolytic enzyme which is also called as angiotensinogenase, because this renin allows the angiotensinogen to get released from the liver, and it is produced by juxtaglomerular cells of the kidney and is secreted in response to. So when juxtaglomerular kidneys allow the release of renin into the systemic circulation, and this is released in response of decreased arterial blood pressure. If there is any decreased arterial blood pressure, renin is released, and decreased sodium levels also, then renin is released, and increased sympathetic nervous system. In these three conditions, renin is released into the body in excess amount. So renin is a plasma protein and it allows the angiotensinogen to get converted to angiotensin 2. So when angiotensinogen is released from the liver, renin converts angiotensinogen to angiotensin 1. When angiotensin 1 is converted to angiotensin 2 by ACE, angiotensin converting enzyme, it causes blood pressure increase because angiotensin 2 is a potent vasoconstrictor. And furthermore, degradation of angiotensin 2 by peptidases produce angiotensin 3. If angiotensin 2 gets degraded, it produces angiotensin 3, which is the inactive product of angiotensinogen. This is a pictorial representation of renin, angiotensinogen, this is a pictorial representation of renin, angiotensin, aldosterone system. Here we can see the angiotensinogen is released from the liver and angiotensin is converted to angiotensin 1 in the presence of renin, which is released from the kidney. And angiotensin 1 is converted to angiotensin 2 by ACE, angiotensin converting enzyme. And when angiotensin 2 is released into the systemic circulation, it has various pharmacological actions. And let us see the effects, side effects, contraindications and uses of these various classes of antihypertensive drugs. First class of drugs are diuretics. So diuretics are mainly used in the renal failure. If there is any renal failure, then diuretics are used. They are used in the hypertension also. And the effects of diuretics include fluid depletion, sodium washout, improves congestive heart failure, systolic function and calcium saving. These all are the effects which can be found when diuretics are given. And side effects. There are side effects of diuretics, like when diuretics are given in excess amount, then potassium secretion will be there. Increased potassium secretion is also not good for the body because there occurs excess vasodilation. And increase in the uric acid, increase in the calcium, increase in the total cholesterol, LDL cholesterol and HDL cholesterol. There will be increase in the LDL cholesterol and total cholesterol, and there will be decrease in the HDL cholesterol. And torsade D points. Torsade D points is a condition which occurs in arrhythmia. And contraindications, when these drugs are to be contraindicated, or when these diuretics are not to be used. They are not to be used in gout because gout is a result of deposition of uric acid crystals in the synovial fluid. The synovial fluid gets replaced with uric acid crystals and that results in the gout. So when the diuretics are given in the condition called gout, there will be increase in the uric acid by diuretics. So when diuretics increase uric acid in the bloodstream, then uric acid gets deposited in the synovial fluid in place of synovial fluid and causes or potentiates or shows synergic effect of gout. And hypokalemia, dyslipidemia, uncontrolled diabetes mellitus and erectile dysfunction. So in these conditions, then the diuretic should be contraindicated. And beta blockers have various effects, like they are used in angina, they are used in hypertension, they are used in arrhythmia, and they have various pharmacological actions also. And beta blockers show the effects of decreased heart rate, decreased force of contraction of the heart, decreased conduction of impulse in the heart, decreased myocardial oxygen demand, and improves ischemia and congestive heart failure and migraine. These are the few effects which are shown by beta blockers. And side effects. What are the side effects which are caused because of beta blocking drugs? Decreased work capacity, fatigue, loss of libido, nightmares, and increased triglyceride levels, that is LDL and HDL ratio also may be increased because of beta blocking drugs in high dose. And these beta blocking drugs should be contraindicated in bradycardia because bradycardia is a condition where there shows decreased force of contraction. So beta blocking agents, if they is given in the condition of bradycardia, then that gives synergetic effect. And prinzmetal angina, COPD, coronary obstructive pulmonary disorder, dyslipidemia, pheochromocytoma. Pheochromocytoma is a condition where the inflammation of adrenal gland takes place, and smokers and old hypertensives. The other class of drugs are alpha blocking drugs. Alpha blocking drugs shows the effect of improves carbohydrate metabolism, used for diabetics but not if neuropathy is present. If a person is suffering from diabetes and having neuropathy condition, then these alpha blocking agents should be strictly contraindicated or should not be used. And alpha blocking drugs will produce the effect called decreased LDL levels and triglycerides and increased HDL, which is a very good symptom. And side effects. What are the side effects of these alpha blockers? Common side effects like headache, drowsiness, dry mouth, weakness, palpitation, blurred vision, fluid retention and postural hypotension can be observed as side effects in alpha blockers. And these alpha blocking drugs should be contraindicated in the case with terazosin and doxorubicin. When terazosin and doxorubicin are given, alpha blocking drug called prazosin should be contraindicated, because when prazosin is given in combination with terazosin and doxorubicin, then that occurs adverse effects. And there are high incidences of stroke also when prazosin is given in combination with these drugs. And calcium channel blockers. Let us see the uses of calcium channel blockers. Calcium channel blockers are used in arrhythmia, hypertension, angina and various other cardiovascular disorders. and it produces effects like there will be no sedation in the elderly patients, and there will be anti-arrhythmic effect because of verapamil, and they will neutrally act on lipidemia. There won't be any fluctuations in the lipid profile when calcium channel blockers are used, and it is used in vasospastic angina as well as asthma. And side effects. What can be the side effects of these calcium channel blockers? So there will be fluid retention. The congestive heart failure condition may be worsened if the person is suffering from congestive heart failure. If calcium channel blockers are given to that person, then CHF effect can be worsened. Gastroesophageal reflux, ankle edema, difficulty in bladder voiding. These are the side effects of calcium channel blockers. And these should be contraindicated in tachycardia, arrhythmiasis, congestive heart failure, volume overload with beta blockers. In all these conditions, calcium channel blockers should be avoided. Not all calcium channel blockers, but few of the calcium channel blockers which shows these adverse effects should be contraindicated. Next, ACE inhibitors, angiotensin converting enzyme inhibitors. So these show the effects of retard diabetic neuropathy. So diabetic neuropathy will be retarded or it will be decreased, and regress left ventricular hypertrophy, and no sedation and postural hypotension used in asthmatics and diabetics, and no hyperkalemia and hyperaldosteronism will be seen. If ACE inhibitors is given, aldosteronism or hyperkalemia, which are the main causes of blood pressure, cannot be seen as the effect. And let us see the side effects of these ACE inhibitors. ACE inhibitors causes bradykinin accumulation, which bradykinin, when it is released in excess amount in the body, it produces dry cough. So bradykinin accumulation or accommodation will take place in the blood and increase serum potassium and decreases glomerular filtration rate. These are the few of the side effects of ACE inhibitors. And these ACE inhibitors should be contraindicated or should not be given in the conditions of pregnancy, or if the creatinine level is greater than 3 mg%. This creatinine is calculated in mg%, and if it is this creatinine, urine creatinine level or blood creatinine level is greater than 3 mg%, then ACE inhibitor should be contraindicated, and it should not be given in bilateral renal artery stenosis and angioedema with NSAIDs and antacids. NSAIDs are non-steroidal anti-inflammatory drugs, and when angioedema, if the patient is suffering from angioedema or taking NSAIDs and antacids, then ACE inhibitor should be contraindicated. Let us see the other class, angiotensinogen 2 receptor blockers. So these class of drugs show the effect of, usually they have normal side effects like headache, dizziness and all. Apart from that, stroke prevention with candidatin in elderly patients with systolic hypertension. So when candidatin is given in elderly patient, the stroke can be prevented. And what are the side effects? What can be the side effects of these angiotensin 2 receptor blockers? Hypotension, if there is given angiotensinogen 2 receptor blockers are given in high amount, it causes hypotension, that is decrease in the blood pressure when the blood pressure will be decreased than the required amount, and hyperkalemia, headache, dizziness and upper GI side effects, upper GIT, gastrointestinal side effects can be observed, and this angiotensin 2 receptors are strictly contraindicated in pregnancy condition. Central sympatholytics. Central sympatholytics. These show effects of decreased noradrenaline level. If central sympatholytics are given, there will be decreased noradrenaline levels. And side effects include common side effects like sedation, mental depression, dry mouth, constipation, fluid retention, impotence and bradycardia or postural hypotension. These are the few of the side effects of central sympatholytics. And these central sympatholytics should be contraindicated in tricyclic antidepressants. These are the class of antidepressants, and chlorpromazine and this chlorpromazine which taken with antihypertensive or when central sympatholytics are given in combination with chlorpromazine, then it reduces or it completely abolishes antihypertensive effect. Then there will be no use of giving central sympatholytics in hypertension condition. Next, vasodilators. What are the effects of vasodilators? The vasodilators show the effect of directly acting arterial vasodilation. Obviously, when vasodilators are given, they directly dilate the arteries, or they directly show the dilation of the arterial blood walls. And side effects. The side effects include angina. When these vasodilators are given in excess amount, then it causes angina and myocardial infarction and rheumatoid arthritis, fluid retention, edema, flushing and nasal stiffness. And these vasodilators should be strictly contraindicated in elderly patients with ischemic heart disease. The patients who are suffering from ischemic heart disease, then these vasodilators should be strictly avoided. Let us see the treatment of hypertension. We saw the class of drugs which are used in the treatment of hypertension. Let us see how these drugs are used in the treatment of hypertension. What are the main indications while we are treating hypertension? If a person is suffering from hypertension, what are the conditions or what are the implications or indications we have to observe or take or should be taken care? First thing is whether the person is suffering from heart failure, coronary artery disease, myocardial infarction, stroke, diabetes, chronic renal failure. First, we have to see whether these indications are present, also present along with the hypertension if a person is suffering from hypertension. Next, let us see the combination therapy. In a single category or singly also the drugs can be used, but in combination therapy they show more effect of antihypertension. So, what are the combinations which can be used? Sympathetic inhibitors, except beta blockers. What are the sympathetic inhibitors are there? Like alpha blocking agents and vasodilators. Alpha blocking agents and vasodilators along with diuretics can be used as combination. The other combination include diuretics with beta blocking agents or calcium channel blockers with beta blockers, ACE inhibitors with beta blockers and vasodilators with beta blockers can be used in combination. And the other combination include hydrolazine, that is the diuretic drug called hydrolazine with beta blockers can be used, and calcium channel blockers with beta blocking can be used. In the first case of diuretics plus beta blocking agents, it shows or it blocks the renin release. But hydrolazine when combined with beta blocking agents, it shows tachycardia decrease in the tachycardia effect. And ACE inhibitors, angiotensin converting enzyme inhibitors can be combined with diuretics. There are 3 drug combinations. Till now we saw 2 drug combinations. Now let us 2 category of drug combinations. Let us see the 3 drug combinations. Here the first combination include calcium channel blockers plus angiotensin converting enzyme or angiotensin receptor blockers and diuretics. These 3 drugs can be given in combination for more or better effect of antihypertension. And second combination is calcium channel blockers with beta blockers and diuretics. And third class is angiotensin converting enzyme inhibitors or angiotensin receptor blockers with beta blocking as well as diuretics. When should this hypertension drugs should be combined, or when should these hypertension drugs or with what drugs the hypertensive drugs should not be combined with? So never combine antihypertensive drugs with alpha or beta blockers and clonidine. When these antihypertensive class of drugs, when these beta blocking drugs of antihypertension, when combined with clonidine, it shows antagonism. It is antagonistic effect. And nifedipine should not be combined with diuretics because it shows synergistic effect. And hydrolazine should not be combined with DHP or prazosin, that is dihydropyridine or prazosin, because they both show same type of action. When these 2 drugs are combined, then it shows synergistic effect. And diltiazem and verapamil, which are calcium channel blockers, should not be combined with beta blockers because bradycardia, it causes bradycardia. Not all calcium channel blockers, only diltiazem and verapamil calcium channel blockers should not be combined with beta blockers. And methyl dopa and clonidine should not be combined with antihypertensive drugs. Next, hypertension and pregnancy. How this hypertension and pregnancy are related. So no drug is safe in pregnancy. So when pregnancy, if a woman is conceived or if a woman is pregnant, then lot of care should be taken. So without any doctor's advice, any medication should not be taken, especially antihypertensive drugs. So the antihypertensive drugs are never safe for pregnancy women, and diuretics, propranolol and ACE inhibitors and sodium nitroprusside, which are potent vasodilators or smooth muscle relaxants, should be avoided in pregnancy condition. And the safer drugs, if a pregnant lady is suffering from hypertension, what can be the safer drugs if she can use in the prescription of doctor or with the prescription of doctor? So safer drugs are hydrolazine, methyl-dopa and cardioselective beta blockers and progesterone. These are the few category of antihypertensive drugs which a pregnant woman can use if she is suffering from hypertension. Next, hypertensive emergencies. If a person is suffering from hypertension, what are the emergency conditions we can see? One is cerebrovascular accident or head injury with high blood pressure. If a person is having severe blood pressure, then that causes cerebrovascular accident or head injury. That is, the nerves of brain blood vessels will get ruptured and there will be hemorrhage, brain hemorrhage. And left ventricular failure with pulmonary edema due to hypertension. If there is severe hypertension, then the person will have left ventricular failure. The left ventricle will not function properly and he'll have pulmonary edema. And third one is hypertensive encephalopathy, angina or myocardial infarction with high BP, acute renal failure with high BP, and pheochromocytoma or cheese reaction and clonidine withdrawal. These are the few conditions where the hypertension is considered as an emergency condition. Let us see the drugs where this hypertension emergencies can be reduced or given as a first aid for these hypertension emergencies. First is sodium nitroprusside, which is a vasodilator in the dose of 20 to 300 microgram per minute should be given, and this dose should be always monitored. And the second drug is GTN, that is glyceryl nitrate or nitroglycerin, should be given in the dose of 5 to 20 microgram per minute. And while this GTN or glyceronitrine or nitroglycerin is usually given in the emergency conditions of cardiac surgery or myocardial infarction or angina. And esmolol should be given in the dose of 0.5 mg per kg as a bolus, that is IV, and 50 to 200 microgram per kg per minute based on the body weight. Per 1 kg of body weight, 50 to 200 micrograms of esmolol per minute is given, and useful in reducing cardiac work. The cardiac work or excess stress on the cardiac or heart can be reduced. And phentolamine is used in the condition of pheochromocytoma or cheese reaction in the dose of 5 to 10 mg IV intravenous. What are the drug interactions of these antihypertensive drugs in dentistry? Because in dental conditions we usually give anesthetics, and when these anesthetics are given, then there are few drugs which causes drug interactions with these anesthetics. Let us see the first interaction, local anesthesia. When local anesthesia is given and the person will take non-selective beta blockers. When a person will take non-selective beta blockers and he is given local anesthesia, then it causes increased local anesthesia toxicity. That causes toxicity of the local anesthesia. And epinephrine and non-selective blockers are given. When epinephrine is given in combination with non-selective beta blockers, it causes increased cardiovascular effects. There might be more worsening of the cardiotoxicity. And when long-term use of NSAIDs are usually given for pain, or they are shown analgesic effect, non-steroidal anti-inflammatory drugs. So they may antagonize the antihypertensive effect of these drugs. When NSAIDs are used for long term, then the antihypertensive effects of the drugs will be reversed or they may be antagonized. The other combinations or contraindications are general anesthesia. General anesthesia is given, and along with that, and angiotensin converting enzyme inhibitors or angiotensin receptor blockers are given, then that causes severe hypotension. And when NSAIDs are combined with ACE inhibitors or angiotensin receptor blockers, then the effect will be nullified, or there won't be any effect of NSAIDs. And when NSAIDs are combined with diuretics also, the NSAIDs effect will be nullified, or there won't be any effects. So these are few of the implications or drug interactions of antihypertensive drugs when used in dental condition. This is about antihypertensive drugs.